to today's webinar series. My name is Eric Ream, and I lead the benefits practice at Seubert Associates. Briefly, Seubert is a full-service consulting firm with four primary disciplines in commercial insurance, surety bonds, employee benefits, and private client risk. We understand there are a lot of ways to finance the important employee benefit of health insurance. Today's focus will be around a newer, innovative healthcare financing option called an Individual Healthcare Reimbursement Account, referred to as an ICHRA. The format of today's webinar will include an hour of presentation with periods for questions, which can be submitted in the Q&A in the Zoom toolbar. If we are unable to get to specific questions, we will certainly follow up with this transcript with all answers to any submitted question. Please allow me to introduce to you today's presenter, my colleague, Doug Moore. Doug is constantly looking to understand new, innovative ways for our clients to improve benefits and their healthcare spend. Our topic today, the ICHRA, definitely is a great example of an innovative concept Doug has researched. Doug quickly immersed himself in learning all he could about the ICHRA pretty much from the day one the final regulations were processed. As a result, on January 1st, 2020, the first day you could have an ICHRA, 3 of our clients were already taking advantage of it. Since then, Doug has continued to lead the strategy, helping more of his clients and other Seubert clients in our firm learn, evaluate, and then sometimes implement an ICHRA. As a result, Seubert now has 12 clients with an ICHRA with carriers in Western PA and with different ICHRA strategies and plan designs. Also, Doug has worked so closely with both of these carriers on the ICHRA related matters, they typically come to him whenever they have questions about the concept. He has partnered with both carriers to help bring to market new products in the individual health insurance space, specifically designed for the ICHRA market. Finally, Doug has worked closely with some of the leading administrators of ICHRAs in the United States to help them refine their service offering and develop new capabilities to better support this growing market. So with that, Doug, can you please introduce the concept of the ICHRA and why you sometimes call it 401k style health benefits?
Sure. Thanks, Derek. Appreciate the introduction and getting us kicked off. The Individual Coverage Health Reimbursement Arrangement, or ICHRA, as we like to call it, is something that came out of federal regulations that were released by the government back in 2019. We first saw the regulations in early 2019, and then they were finalized relatively quickly in mid-June of that year. And that allowed ICHRAs to come into being on January 1st, 2020. Frankly, a lot quicker than a lot of people thought they might. And really what an ICHRA does is it allows an employer of any size to reimburse employees for major medical or Medicare health insurance premiums or pay for them to the carriers directly. And they can do all of this on a tax-free basis, tax-free for the employer and continue to be tax-free for the employee's portion. Now, that's a big deal because if you know your health insurance history at all, you'll know that prior to 2014, individual health insurance coverage in most parts of the United States, including Pennsylvania, was not available on a guaranteed issue basis and with no medical underwriting and no pre-existing conditions. The Affordable Care Act changed all of that. But when that went into effect in 2014, what we also saw was that employers could not do something like an ICHRA and reimburse employees for premiums. Well, the ICHRA took the tax-free bit and added it to the guaranteed issue bit for the individual policies themselves and created something unprecedented in US history. And that's this ability for the employers to provide this tax-free reimbursement, but for individual policies. Now, we refer to it often as 401k style health insurance. And, there's a reason for that. The 401k, as I think most people know, is considered to be a defined contribution form of a retirement plan. And we think ICHRAs are positioned much the same way for health, but for health benefits. Both types of programs allow the employer to transfer the risk associated with providing the benefit. In the case of 401k, obviously you're transferring the risk for someone's retirement plan benefit. And with an ICHRA, you're transferring the risk associated with an individual member's health status that is affecting your rates if you're a larger employer, or if you're a smaller employer, just even the rising premium costs associated with providing the benefit. So 401ks, interestingly, started about 40 years ago, back in 1980, and it took a couple of years before adoption of them really started to take off. When the federal government released the final ICRA regulations almost 2 years ago now, they came out and said, well, we predict that 11 million people in the next 5 years will convert over to an ICRA, and about 7 million of those will be people that are currently in the group market today. Now, obviously, we don't know yet if that's the way that this will all transpire, if it'll be correct or more or less. But when we look at what happened with defined benefit pension plans, they were largely replaced over time by 401ks. You see the stats here on the slide that show how the market has changed over time. And really, most of us don't know too many people, I think, that are not public sector employees that are covered by a defined benefit pension plan. A 401k or similar style defined contribution plan is much more the norm. So let me share with you a few of the benefits that we've identified for the ICHRA for employers and for employees alike. So for employers, its ability to offer choice of any ACA compliant individual plan on the market for those employees under age 65. And importantly, for employees over age 65, now the ability to involve Medicare. So no more, in other words, no more one size fits all approach. Many employers have just a single plan option from a single carrier that they offer to employees. Well, here with ICHRA, we can get away from that. Big deal, as I mentioned on the previous slide, we think is the ability for an applicable large employer, so that's any employer with more than 50 employees, to exit the risk game. What do I mean by risk game? Well, that's the whole idea that your premiums are impacted by the claims or health risk status of the individuals that are in your group. We'll talk more about that on a future slide. For an employer, you also have the ability to have the ICHRA keep you compliant with all your ACA-related employer mandates. Just by offering an ICHRA in any amount, you are offering what's called minimum essential coverage, which avoids penalty A under the employer mandate. And by offering affordable coverage, you're also satisfying your penalty B obligation. And we'll talk a little bit more about that as well on a future slide. So for the employee, what are the advantages? Well, they like the idea that they can select a plan that meets their needs best. That includes, what do they want their out-of-pocket costs to be? What do they want what doctors and hospitals do they want in their network? And also things like what medications are on their prescription drug formulary. Employees like that they continue to benefit from the tax advantages that they have on a group plan. They can continue to pay their share of the premium in most cases on a pre-tax basis. And I think this last point may become more and more relevant as time goes on, and that is that the employees can keep the same health plan if they retire or change jobs. That kind of decouples the idea that your health plan is always tied to work. Yeah, your employer may be financing it while you're working, but then when you leave employment, you can take that with you. And it is the policy that you own. It's not just your, electing, say, COBRA under your group plan. So ICHRAs have some basic requirements, and the 7 of them that the government prescribes are listed here on the slide. I want to touch on a couple of them in particular. Touch on the important point is that employees must not be eligible for both the ICHRA and the traditional group health plan. So you can't say, if you like the ICHRA, great, here you can go over here and participate in it. But if you just want to stay on a regular group plan, you can do that. No, that's a no-no, big no-no. The employer can, though, offer the ICHRA to a certain class of employees while not offering it to others, and perhaps offering the group health plan to others. And we'll talk in a minute about what those classes are. All employees that are eligible have to be told about it and given the ability to opt out. And there has to be substantiation provided for that individual coverage. In other words, proof that it was actually purchased. But we've kind of figured that out in easy ways to make that happen for employees, which we'll share towards the end of the presentation. So here are the classes that employers can have for their ICHRA. And there's a fairly decent length list here, but I want to touch on the ones that we see as most common. First of all, I think most employers are providing health benefits today to all their full-time employees because they want to stay compliant with the ACA rules if they're a large employer. If you're a small employer, perhaps you have full and part-time employees that you're looking at. But salary and hourly employees is an interesting distinction that the classes allow for here. Notice it's not management, non-management, but salary versus hourly, very specifically. But the one that I've been most focused on here is employees working in the same geographic location. Because while all of the ICHRAs that we've done here at Seubert to date have been for the entire population of a company that's full-time, I'm aware of many employers that have implemented an ICHRA just for a class of employees based on a geographic location. For example, perhaps you have a location in, say, California. We've run into this a number of times in my career here at Seubert. Where a employer maybe based here in Pittsburgh opens an office in California where Kaiser Permanente is popular, and Kaiser practices aren't in network with the local health insurer from Western Pennsylvania. And so we struggle with that sometimes. Well, you could say, hey, in California, I want to do an ICHRA, but the rest of the country, I'm going to keep on my traditional group health plan. And other examples, as you could think of, it really could be in any state where you could vary the offering of an ICHRA there and not in other locations. There are some minimum class size requirements that apply if you're going to set up by class, but interestingly, geographic location by state does not have a minimum size requirement. So in theory, you could do that even for just a few employees. Now, there's two different types of ICHRA, really. The one that we're going to focus most of our attention on because we've seen it be the most prevalent, particularly for larger employers, again, over 50 employees, is the one on the left, the premium reimbursement only approach, where employee uses the money if they would want to participate for premiums, the cost. Any money that's left over, they don't get to keep. They don't have any other use for it. It just in essence isn't used. However, there is another type of an ICHRA where you can have it applied towards premiums and any what they call Section 213D qualified expenses. So this is going to be the same type of stuff that could be reimbursed under a flexible spending account or a health savings account. These are, again, in our experience, much less common. There's, while they do offer additional flexibility in terms of benefit, there is significantly more administrative burden associated with that. So time will tell to see how popular each of these styles ends up being. I really think that the premium reimbursement only, though, will be the more popular choice in the larger group market, and perhaps in the smaller group market, we'll see a blend of the two.
So Doug, you mentioned about just right there on the larger group market and the smaller group market. And as we kicked this off, we've certainly implemented a dozen ICHRAs on that premium reimbursement only option right now. But can you talk a little bit about just what the feasibility for employers to do this relative to size? And then once we talk about the different sizes, is there different rules for this based on how many employees I have at my company?
Yeah, sure. I'll kind of break it down into small first and then move on to large because there's a little bit more going on in when it comes to larger employers. So again, smaller employer is going to be somebody with, generally speaking, with fewer than 51 employees. Somebody that's not considered an applicable large employer. By now, we all should know who we are. Importantly, in the small group market, as you may know, if you're a small employer, there's no affordability testing that applies. So what reasons would there be that an ICHRA might be attractive to a smaller employer? Well, number one, the choice of insurance carriers. So for example, instead of, if you're here in Western Pennsylvania saying, well, I had to select between Highmark or UPMC, and all my employees had to go with that, employees could decide for themselves what they wanted. Better choice of plans. Some people may want a plan that's health savings account compatible, some may not. Some may want a richer plan, some may not. Importantly for small groups, though, there's this issue of minimum participation requirements. So insurer may say, hey, you've got to insure at least 50% of all of your full-time employees. Don't care if some of them are opting out because they're on their parents' plan or on a spouse's plan. We need 50%. And that may not work for you. So, and ICHRA says, don't worry about that. There is no minimum participation requirement. There's much lower costs for Medicare aged eligible employees. We're going to talk about Medicare a little bit more as we move through the presentation, but that's important because more and more people are working past age 65, and often they need to stay on the group health plan. But with ICHRA, they can go on to Medicare Part B and get a Medicare Advantage plan or a supplement. That's going to be far less expensive for both the employee and the employer when they do that. And then one other thing that we're kind of paying attention to here in the smaller group market is the ability to combine the ICHRA with other types of health benefit solutions. One example of this is something some of you may be familiar with called direct primary care. It's basically a membership-based primary care relationship where you don't pay any co-pays or anything to go, and you can see the doctor as often as you like and can usually spend more time with them and so on and so forth. These are growing in popularity. And so some employers might say, hey, I want to buy that for my employees and then give them some money to use for an ICHRA. But because they don't have to worry about the affordability testing, that might work well in their budget. So that's kind of how I see it setting up for the smaller folks. Now, for the larger employers, again, a little bit different. As I talked about a few slides back, the biggest deal for me with the ICHRA for applicable large employers is this idea of being able to exit the risk gain for whatever portion of the population you're putting into the ICHRA arrangement. I don't think that comes as any surprise to anybody on this call that there's high volatility when it comes to health insurance costs. And it's not unusual to see rate increases of 25% or more in a given year. And last year, in my own personal client base, I had 2 clients that received increases of around 70%. Now, I don't know about you, but I don't know how anybody can budget for 25%, let alone 70% increase in what is for most employers now their second biggest employment related cost after wages. So, personally, I think a lot of employers have had enough of this. And, whether it's happened to you last year, a couple of years ago, you think it might happen to you in the upcoming year or years, that uncertainty, I think, is unnerving for a lot of folks. So, and even self-insured employers, right, who are generally even larger and have more lives to generally spread that risk out over, they can still see significant volatility in claims. And that may be in one location within their company, or it may be across their whole employee population. So I think employer just needs to ask themselves, how do I feel about being in the risk game? If I'm good with that and I have a lot of aggressive strategies in place to help manage costs, wonderful. If not, or I don't want to be, I don't want to deal with that, again, ICHRA can provide that unique type of relief. And that's because really, rates in the individual health insurance market are not based on claims or health factors. The only factors that are influencing rates for a given plan are going to be age, nicotine use, home zip code or location, and nicotine use. So never is somebody's rate going to be based on whether they had a claim or whether they just got diagnosed with a serious medical condition. That's off the table completely, full stop. And that's a big deal. And so you might be thinking to yourself, okay, so I get out of this highly volatile group market. What's the individual market? What does that look like cost-wise? Well, frankly, we've seen much lower volatility in the individual health insurance market, particularly over the last several years. And we expect that to continue as this market continues to grow. For example, here in Western Pennsylvania, premiums were essentially flat, moving from 2020 into 2021. And even the year before, 2019 into 2020, was only about a 3% differential. And as I mentioned, the early volatility that we saw in this market when carriers were really trying to figure it out, and the Obama administration was replaced by the Trump administration, and there was some stuff going on there. We really don't expect that to be repeated, particularly now that Pennsylvania has its own state-based exchange, and the Biden administration has taken some steps, frankly, lately to strengthen the ACA. However you feel about the ACA, but I think the point here is that stability is expected in that market, much more so than what we expect to see in the group market moving forward. Now, I've referred now a couple of times to this idea of affordability when it comes to ICHRA. And this is not a new concept. You know, all of you who are applicable large employers know that you have to keep your group health plan affordable under the ACA rules if you want to avoid potentially being subject to some of the ACA penalties. Now, with ICHRA, there's somewhat different testing used to determine what's affordable than we use in the group plan market. At a high level, what I'll tell you is that there's a benchmark plan that we have to test off of in each geographic area. It's what's called the lowest cost silver plan that's available on exchange in a given rating area. So here in Western Pennsylvania, we have our own rating area that encompasses about 10 counties. So we test on a rating by rating area. And that's important because with a silver plan on the exchange, that plan has a higher what we call actuarial value than what you're permitted to have in the group market and still be affordable, which is a 60% level plan. So said another way, it's a little more challenging sometimes to make sure that your plan is affordable under ICHRA than it may be in the group market, particularly if you're using in the group market a plan with a really low actuarial value. And some employers are doing that, not all. But those nuances are stuff we help our clients interpret and figure out and make sure that you're going to be okay. There is some flexibility in doing this affordability testing where we can look at either the work location of the employee or their actual home location. That can be helpful if you have employees coming from all over to work and you want to keep the testing a little simpler. And we can still use any of the affordability safe harbors that have been around since 2014, such as the federal poverty level or rate of pay safe harbor as the two most common. And we do this testing on an employee by employee basis. So basically you give us the data, we analyze it, and we tell you, here's where you would need to set your contribution amounts in order to be affordable for everybody. Now, I don't want to go too deep on this, but suffice it to say there are limited situations in which making the ICHRA unaffordable for certain employees, particularly lower paid employees, might make some sense. But again, that's something that we would go over with any employer that was looking at an ICHRA as we did the affordability testing.
So Doug, I know we've learned a lot over the past couple of years in regards to ICHRA administration and really trying to understand how individual health insurance plans are structured. Like you and I know that retention and recruitment of employees is critical in this job market. And a lot of people on the phone are probably sitting there saying, well, what do these things look like? What does this mean to me? So can you go through some sample plans? Obviously we picked Western PA here, and talk a little bit about how these are structured. So participants on the call kind of think, well, this is how this would line up for me based on what is potentially offered in the individual health insurance market.
Sure. So Western Pennsylvania is actually, in my opinion, a really, really good individual health insurance market. And many other experts across the country who don't have the bias that I have living here actually agree. So I guess that's cool. The reason I think it's particularly good is that we have the two most recognizable health plan names in Western Pennsylvania as the current issuers of individual plans here. And that's Highmark and UPMC. In most counties in Western Pennsylvania, both Highmark and UPMC offer either two or sometimes even three different network options. So that's very nice in terms of choice. There is a fairly substantial delta in the premium between the really broad network plan offerings and the narrower network options. We're actually finding, though, that the vast majority of employees are going with the narrower network options because, frankly, it's meeting their needs, and they don't need everybody to be in their network. When we're buying health insurance coverage on a group basis for our employees, we might say, oh, I have to have a plan that or a network that has both AHN and UPMC providers in it. Great. But that may force you to have to choose a health insurance product or carrier that is more expensive than you otherwise would need to satisfy the needs of your whole group. Don't have to worry about that here, where employees are picking the network that they want for themselves. Both Highmark and UPMC, and this is typical of every market in the United States, frankly, though, offer plans at the bronze, silver, and gold, what are called metal levels. That's a term that the ACA started in 2014 that we find used in both the small group market and the individual market. And this simply refers to the actuarial value of the plan. They offer HSA compatible plans and non-HSA compatible plans. So again, a lot of flexibility there within the offerings. We already talked about the premiums changes over the last couple of years, which have been favorable. And we know, because I've been working with both Highmark and UPMC closely on this, that they're developing some additional plans specifically designed for ICHRA in what's called the off-exchange market. Again, these are the plans that allow employees to pay for their share of any premiums pre-tax. So that's really important. But we expect some new plans here in 2022 to provide even more choice, which again, I think is great. Both Highmark and UPMC, I must say, have been very friendly to ICHRAs and have worked really well with trying to adjust their systems and processes to adapt to ICHRA. And I think there's many carriers around the country for whom the same thing could be said. Some carriers are actually designing entire strategies around ICHRA. Others, maybe some more established traditional ones, they're a little slower to the game, but we'll see. And it will be interesting to see if we'll get any new carriers in our market in 2022. Out in Philadelphia, for example, a new insurer entered the market last year called Oscar Health. It's one of these carriers that's really focused on the ICHRA market. So don't know if they're coming to Western PA, but we'll be keeping an eye on that. Eric, you asked me to talk about what do these plans kind of look like that are available out there today. Again, there could be some differences in 2022. But what we've seen so far on the ICHRA is that the most popular metal level of plan is, maybe not surprisingly, the gold level. And this is usually what employers want to see me show them, because they're like, okay, if this is the best, then I know that it steps down from here. So you see the two Highmark plans, the two UPMC plans here. Notice that Highmark actually offers a plan that actually has no deductible, but it does have a significant 40% coinsurance for services that are not subject to the copays, like doctor visits and urgent care and prescriptions, which are just subject, to a copay, no deductible, and no coinsurance. Their most popular plan actually is that $800 deductible plan, probably because it has a lower coinsurance and a lower total maximum out of pocket, which is what TMOOP stands for. UPMC, their plan, they actually offer a little bit higher of a deductible in the gold level, but lower coinsurance and the lowest overall copay for primary care doctors. And then my personal favorite plan is actually the last plan there, the UPMC HSA offering, because it has the lowest total maximum out of pocket and it allows you to have a health savings account, which I really like. But different strokes for different folks. I also want to remind everybody here that there are silver and bronze level plans available as well. Silver plans are generally going to have a deductible like in the $2,000 to $3,000 range and a little bit higher TMOOP, a little bit higher copays. Bronze plans have the highest deductibles of all, close to the limit that we're allowed to have, which is around $7,000 deductible. It's more like catastrophic coverage. Certain people like that. And there's typically about a 15 to 20% differential in premium to go from gold to silver and another 25% to go down to bronze. So you can have some pretty significant fluctuation in premiums here. But again, the employee is deciding how they want to spend those dollars. And one last point I'll make when it comes to plan design, everything we're looking at here is for that underage 65 population. Again, anybody that's over 65, and a lot of you have employees continuing to work for you over age 65. Personally, I think that's a trend that will only continue. They actually will be, again, going on Medicare Part B and Part A and buying a Medicare Advantage or Medicare Supplement plan. And in most cases, these folks that go on Medicare are able to get plans with very little out-of-pocket expense to them. Frankly, they love it. ICHRA and Medicare go great together. But that's another conversation for another time to get deeper on. So I hope that did the trick, Eric, with what you're asking.
Yep. Next, Doug, again, with how we got to the point of advising our clients on if an ICHRA makes sense, there were certain characteristics within the clients to make sure this was the right fit for them. And there's a lot of legwork as far as like how we got to that point. So like same time, like, you know, we've got our bumps and bruises along the way, really understanding how to make this an efficient process for our clients. And can you just talk specifics on the candidacy for a good ICHRA? At the same time, like can you talk about the challenges for employers when they're looking or evaluating to put one of these things in?
Yeah, sure. And because there's no doubt that ICHRA is not a strategy right now that is appropriate for everyone. I would never suggest that. But here are some characteristics that we've determined make a good ICHRA candidate. The first one's probably pretty obvious based on some of my earlier comments, and that is, you were faced with a higher than average group health insurance premium, or you have higher than average health insurance premiums, or you just got a large, or you're about to receive a large premium increase at your next renewal. As we mentioned, with ICHRA, you exit the risk game. So if the reason you would be paying higher than average premiums or be experiencing a big increase is because something claims-wise and or health risk-wise is going on in your group. And if you want to alleviate that, walk away from that, again, you probably are a good candidate for ICHRA. It does help, of course, to have most of your employees living in areas where there is a competitive individual health insurance market. Western Pennsylvania is one such place. I'm going to talk in a little bit about where is not, what are some not so good markets are. Another thing is employer contributions towards the cost of single-only coverage, which is what affordability is based on. How much do employees have to pay for single? If the employer is contributing, say, about 70%, that's not a hard and fast number, but generally, Eric, about 70% or more of the premium, then they're usually a pretty good candidate. And then this last one's kind of, I guess, a little bit of a squishy comment, but the willingness to spend time educating your workforce about the concept and providing the appropriate time for employees to get the support they need to enroll. This is not like a traditional year-to-year enrollment. Hey, we're changing from carrier A to carrier B. That's a change, and that's important, and you're going to have a meeting about that. Here, you're probably going to have to do even more in-depth education with your partner, like a Seubert, to do that, and expect that to take a little bit more time than usual. So bottom line is you can't just wait until, you can't say, oh, I'll just wait till I see, what my renewal is going to be, and then try to figure this all out. It's good to, if you think that you're going to be interested in this, to do your evaluation ahead of time and start doing the education and the, providing the support services up front. So that kind of is a segue into, for whom may an ICHRA not be a fit? Well, employers that design to maintain a plan with a really high actuarial value, what do I mean by that? That's going to be a really rich, like 90% actuarial value plan or higher. That's like a $500 deductible, maybe 100% co-insurance. If you're like, I've got to have that. I got to have low out of pocket for everybody. As you saw from our plan designs before, we're not going to be able to match that in the individual market. Now, I would suggest to you two things about this. Number one is that there are other ways, if you want to supplement your health benefits, that you could do so and still have a rich benefit level, albeit with the ICHRA plans still being what they are. Okay. And there's a variety of ways that you could potentially do that. The other thing is that I've found in my career working in benefits that employers tend to approach health benefits from what I call a highest common denominator standpoint. What is the highest level of benefits that I can afford to provide that's going to then appeal to my people who are going to use the plan the most? And that's okay that you're doing that. But what you end up doing is you're buying a lot more benefits than you really need to for most of your population. And I would argue that's inefficient. So, but whether you agree with me or not, I guess isn't important. Just know that if you're like, now I got to have a super rich plan because that's just what it's got to be, ICHRA isn't going to play well with that. Collective bargaining agreements can be an issue. Obviously, if you're dealing with the union, you'd have to decide, negotiate an ICHRA in or out with them. Remember from our earlier slide about classes, though, that you can have union employees, continue to stay where they are and do something different with your non-union folks. If you have a low employer contribution strategy towards your group plan, like, for example, we just split the premium 50-50. You may not be a good candidate because what employees have to pay for coverage is already quite high. There's also what we call employers that have a lockout strategy. Lockout meaning lockout penalties, where an employer might say, hey, we're going to offer a really low value plan, like a 60% actuarial value bronze plan, and we're going to charge as much as we possibly can for it, so that we're affordable, and then we'll offer a better plan, but at a much higher price point. I just consulted with a retail chain recently who thought they wanted to do ICHRA, and we found out they were doing this, and when we did the math, it just didn't make sense for them. They were going to have to give more money per employee towards the premium, and even though it would have meant that their employees could buy health insurance coverage a lot cheaper, it meant their costs probably were going to go up, and they weren't willing to do that. I'm not judging them. It's just, a reality. So we learned, hey, that can be a deal breaker for an ICHRA. And then if you do have a moderate to high percentage of your employees living in areas where the individual market is not particularly competitive, then obviously ICHRA is not going to look so good either. A couple of examples could be here in Western Pennsylvania, within our rating area, which Pennsylvania calls rating area 4, 2 counties, Armstrong and Indiana County, stand out that they don't have as many network options available, and therefore their rates are higher. So that can be somewhat problematic because we have to set rates the same within a rating area for the ICHRA. If we're in another state, that's okay. We can have higher rates in another ICHRA rates in another state, but within a rating area, we have to stay the same. So that can be a potential issue. And then there are specific states, including our good friends to the south in West Virginia. For whatever reason, I'm not smart enough to know, but their individual health insurance rates are very high compared to Pennsylvania. So if you have a lot of employees in West Virginia, ICHRA, again, probably not going to be a fit. But that's all stuff that we can flesh out in the analysis. So quickly, here are some challenges that employers have to deal with when they're considering ICHRA. Challenge doesn't mean it's a bad thing, just means it's something we have to consider. And a couple that I'll touch on that we haven't mentioned already, such as affordability testing, would be that there is currently a 90-day advance notice requirement if you're going to introduce a new ICHRA. Although right now that's suspended during COVID because so many of these notice requirements are suspended. We are actually lobbying the federal government through the trade group that represents ICHRA providers to get this changed because it's really unworkable. And I think the regulators know this, but it just takes time to change these things. But I'm hopeful that within the next 6 to 12 months, this will drop down to either a 60 or a 30-day notice requirement. Rates for those with parent, child, or family coverage. In the individual market, those rates are determined on a per child basis, up to generally 3 kids under the age of 19. Now, why is that a big deal? Well, as we know in the group market, if you have family coverage, it doesn't matter if you're an employee, a spouse, and 1 child, or 10 kids. It's generally speaking, it's the same rate, especially in the large group market. That's not true in the individual market. And what that means is if you give all of your families X amount of dollars based on their age, at the age of the employee, those with more kids, it's going to cost them more to buy individual insurance than those with fewer kids. And that's something that you'll have to budget, or address in your planning and in your education. There are nicotine distinct rates in the individual market. So this is self-reported, but those folks that do report they use nicotine are going to basically pay that additional surcharge. That's going to come out of their pocket in most cases in the form of additional payroll contributions. So everybody's got to understand that. And last but certainly not least, and we've seen this happen on a couple of occasions so far with the ICHRA, is that sometimes the new ICHRA offer is so attractive that you end up picking up more employees than you had enrolled before. Now, is that a good thing or a bad thing? Well, I can't say for you, but I'd argue getting more people covered is good, but you'd say maybe, hey, that's also coming out of my budget. So how do I plan for that? We can help in the modeling, try to determine how many people you may have affected and what's the likelihood that you may pick up some more enrollment as a result.
So as Doug went through the just the characteristics and challenges, like I want to reiterate that like the ICHRA it's a strategy. It's not a Band-Aid. And I think once you'll see some of these results that Doug's going to go through, you're going to see why we are embracing this concept to the point that we are. And you'll see like some of their local or national results that there are some definite slam dunks here. And Doug, I put reality behind this as when this does make sense, when we identify as a real opportunity, there's real dollars at stake here to invest back in your company. So Doug, can you please kind of go through a couple examples as to what we've had experience over the past couple of years?
Sure. So again, ICHRAs have been around for about 15 months now, and we've implemented 12 employer groups among our clients. All have been for the entire full-time employee population, as I mentioned earlier. 10 were of these implementations were full replacements for what had been a traditional group health plan. The other 2 were for employers who had not previously offered health benefits because they were under 50 employees, but grew to be over 50 employees and wanted to start offering a plan so as to avoid penalties. There's been a wide range of industries that we've done these for. You see some of them listed here. I think a couple of these stand out as really good candidates almost across the board, and that would be nonprofits and home health care. I think in most cases, automobile dealerships fit the profile quite well, but there's really no industry for which ICHRA can't work. Although I would argue that maybe industries that are highly white collar and or high margin businesses would feel less inclined to consider ICHRA, maybe at their detriment, but nevertheless, most of the interest we've seen now has come from organizations in these industry sectors or those that are have a lot of blue or gray collar content. Again, it's not to say that a white collar organization couldn't or shouldn't consider this and benefit from it. The average size client that we've had that's implemented in ICHRA has been just over 100 eligible employees. The largest had 300 folks. And this is the number that kind of pops off the page at me. I hope it does to you. And your eyes are not deceiving you here. The average per employee per year savings so far that we've seen has been just over $3,000. Again, that's per employee per year that's covered on the plan. Obviously, and you're going to see this in our case studies, some have been greater than that. And this isn't just the employer that's benefiting. Employees are typically seeing overall reduction in premium contributions. This is being driven by 2 factors. One are what are then often lower rates in the individual market, as well as employee decisions to select plans with lower costs. Not everybody needs a gold level plan. And that's been borne out in the enrollment process as we've gone through it. And then I think really importantly, we've had very few employee issues with claims, provider network issues, or prescription drugs. So you might be thinking to yourself, okay, so I switch over to this and these plans, employees aren't familiar with them. Are they going to like them? We were a little nervous too, I have to admit, because we didn't do much in the individual market prior to January 1st, 2020. But you know what? It's really worked out well. We have very few issues, no more than we would experience in a traditional group health plan. And I say that in complete transparency to you. And long may it continue, because that's really been great. And it's made employees much more confident in the decision that the employer made for them to make this move, because it is new, it is different, and we get that. Now you may be saying, okay, Doug, that's great. You've done 12. They're in Western Pennsylvania, but I do business all over the country, or just tell me what's going on, big picture here. So our primary ICHRA administration partner, and we do have a couple, by the way, gave me this data. Their average group size has been a little bit lower at 43 employees. Average savings from current rates, they reported to me, it being almost 14%. And they have enrollment in individual health plans across 17 different states. Many of you have heard of the actuarial consulting firm that services the benefits world called Milliman. They also have done quite a bit of work in the ICRA space, and they tell me that their average group size has been over 200 employees. They tend to work only with employers with, say, 100 or more employees, so this isn't surprising. And they have more groups that they've been looking at, and their average savings over current, again, rates has been about 8.4% with enrollment in 31 different states. Bottom line is that ICHRAs are growing. Like I mentioned with the 401k analogy, it took a couple of years before it started to move the needle, and I think the same is going to be true here. So whether you're considering an ICHRA in the short term or medium term, just know that you're not alone, and there's plenty of people locally and nationally that are starting to kick the tires here. So I've included 2 case studies for you. This is my favorite one, I must admit, because it's the most dramatic. A nonprofit organization here based in Pittsburgh, Western PA, with about 300 full-time employees, 220 of whom are on the group health plan. Folks, their group health insurance costs were indeed well above average. I have worked with them for 7 or 8 years. We had done a lot of different things to try to control costs. And the most recent thing we had done prior to ICHRA was we had to move them to a narrower network option with Highmark for the entire employee population. The reason I mention that is that move wasn't particularly popular with a segment of the employees who had providers that they wanted to see who weren't in that narrower network. And so we took some heat for that, but it did save the organization some money. But nevertheless, their health insurance costs were high. And you can see here on the right just how high they were. So look at their 2020 health insurance spend of $3.2 million, split up $2.5 million of employer money and $700K of employee money. We were able to reduce that with ICHRA down to $1.9 million, $900K in savings for the employer and about $400,000 for the employees. Now you might say, okay, well, that's great, that you were able to do all that, but what was the coverage like? Most of the employees took plans that looked very similar to what they had on the group level. Some didn't, and that's reflected in the lower employee contribution amounts as well. But interestingly, 70% of their employees in Pennsylvania, which is where the vast majority of those 220 are, they enrolled in coverage through Highmark. Not surprising, they had Highmark before. 30% though chose UPMC health plan. And that's because obviously they had providers that were in that network that they wanted to access. Now, one other thing that happened here is this group had some employees, not all, that were Medicare aged, that had exited the group health plan previously in favor of Medicare, but who now, because they were covered under the ICHRA, could come back on and participate and have their Medicare costs reimbursed. So we picked up about 10 or 15 new enrollments there. The reimbursement rates for those folks were relatively low, but that is reflected in the spend numbers that you see here in the case study. Another case study real quick is a smaller company, also located here in Western Pennsylvania, that's in the medical device business with 70 employees, 45 on the group health plan. You can see what their costs were in savings. A couple of things of note here where they got hit with a 40% rate increase last year. I mean, again, wow. How do you budget for that? With ICHRA, we were able to basically bring them in flat and where they had been the year before. And what that resulted in is employee contributions remaining the same or decreasing for 90% of the employees on the plan. And you can see here, this company was with one of the national carriers that had both the UPMC and AHN networks available. A lot of their employees were located in Allegheny County, in fact, in the city. And maybe, I don't know if this was surprising or not, but they end up having about 85% of their folks choose UPMC health plan. I think part of that is because UPMC's rates in the individual market right now are a little bit lower than Highmark's in most cases, not all. So that I'm sure was an influencer in the decision. But hopefully what I just did here with the results, both locally and nationally, and sharing this case study is to show you that there are, as Eric said, some slam dunks here where it's just, how could you not do it as a plan fiduciary when there can be this type of savings opportunities available?
So Doug, we have 10 minutes left in our hour, and with ICHRA implementation, being super proactive is really important. So like as far as like using 5 minutes here so we have some time for some Q&A, is talk about the design, and I think most importantly, the educational and hand-holding component of an ICHRA implementation, because it is new. We want to make sure that employees and their families know what's going on. So can you highlight some key items that have to happen in order for this to be successful, as we've done on our 12 current ICHRAs?
Sure. So we kind of break it down into these three phases: plan design, education, enrollment, and then and then administration. So the actual final implementation of the policies and ongoing administration. I'll take each of these quickly for you. From a plan design perspective, we go through and we say, okay, are we looking to do this for everybody or just by class? And then, are we looking to avoid all the penalties? Usually the answer is yes. So we do the affordability analysis. And then, okay, who are the TPAs out there that can do this administration, and work with them on the plan design and how they're going to handle everything. So that's kind of the design phase up front. There's a lot of modeling that goes on. We tell you the data that we need. We crunch the numbers, come back to you with that presentation. Once you've seen that and designed your plan accordingly, when I say design your plan, what do you want your ICHRA amounts to be? And you can vary those amounts, and most employers do, based on single versus family, and also by age. So typically you'll provide lower amounts to younger employees and higher amounts to older employees. Then we move on to education and enrollment. Remember, of course, this is a complete paradigm shift for employees. So we're going to do that significant education up front, typically in a variety of mediums. When COVID moves along, we'll finally be able to get back to doing true group meetings, which is nice. And then what we expect is that many employees are going to be comfortable making plan selections on their own. They know what they want. So let's provide them with easy to use self-service options to be able to do that. And then other employees are going to want highly personalized support to make that plan decision. We're going to provide them with that as well through our partners. So nobody needs to be panicked that, oh, I've got to make this decision and I don't know who's going to help me. No, we trained, very talented and highly specialized professionals on this are going to be doing the support. So that's phase 2 around education and enrollment. And then when it comes to administration, there's really kind of two, I would say, generations already of this. And I don't necessarily think one is better than the other right now, although 2.0 is probably going to be more popular moving forward. So either the employee purchases their policy of choice, typically again through the third-party administrator, so that the reimbursement process is really simple and easy. And then they get reimbursed through their payroll, along with any pre-tax contributions they make. And this process repeats on a monthly basis. And an employer can either reimburse after the premiums paid by the employee, or they can even reimburse just before. So from a cash flow perspective, they don't have to worry about the employee having the money available. There's pros and cons to that approach. I think where, again, what we're doing more of now and what I think the future is this 2.0, which the differential here is that the employer can actually pay these premiums directly to the insurance companies through a payment technology that the TPA is bringing to the table. So think of it like your 401k. You take money out of an employee's paycheck, you add your employer money to it, and off it goes through your payroll system off to a third party who makes sure that it gets into each individual employee's account. Similar thing here, it's just going to the insurance carriers in the form of premium payments. So bottom line is we show our clients the different administration options, help you decide what's right for you. The 2.0 model costs a little bit more than the 1.0 model, but again, different strokes for different folks there.
So Doug, before you kind of get into the action items from the webinar, I don't know if we didn't if I forget earlier, but talk about the notice. Can you reiterate the notice requirement? Then also these individual policies renew calendar year, or they run calendar year. Can you just talk a little bit about that? Because we did have a question about the effective dates of this stuff.
Sure. No, both great questions. So again, on the notice requirement, there is a notice requirement, very specific one under ICRA. There's a template that the feds came up with that we largely follow using the TPA partners. Technically, there is a 90-day advance notice requirement that you notify the employees that you will be offering an ICRA. Right now, the position of all the TPAs is that that notice requirement in terms of timing is flexible because of the fact we're still in the national outbreak period for COVID. But once we exit that, the 90-day period in theory would, not in theory, but would be applicable. And we're hoping to get that reduced because we just think that's not practical. A lot of times the employer doesn't know that far out that they do or don't want to do this, no matter how much we try to get employers to act early. So we will see on that. But those notices would be posted for the employees to review. It would contain all the information that's required, including the amount of their ICRA contributions. And then your second question, Eric, I think was, I'm sorry, it was around the renewal date of the individual plans. All individual health insurance policies renew on a calendar year basis. So if your plan, your group plan that you may be looking to replace some or all of renews on January 1st, it's easy, right? Because that's going to match up. If it's any other date, say July, for example, then you have a decision to make. Do you implement for July 1 an ICRA and tell all the employees, hey, you've got a short 6-month plan year, and we can make some adjustments in terms of ICRA contributions or doing some other tweaks to the program to make that more palatable to the employee? Or do you renew your group plan for 6 months with the eye towards implementing the ICRA January 1? Either way, you can do it. And there's pros and cons, which we could get into on a case-by-case basis. But all individual health insurance policies in the United States that are ICRA compliant are going to renew on a January 1 time period, both for their benefits and their new rates. And typically every year, the benefit levels change a little bit as the plans have to pivot to a little bit to comply with the federal rules. Additionally, rates can and do fluctuate in different states by different levels. As we talked about in Pennsylvania, the last couple of years, they've been pretty stable.
Great, thanks, Doug. So to call to action here is, as far as like our clients, our Seubert clients, we're identifying these as opportunities, and the team is going to start having conversations about how this may look to you. But you want to put some color around next steps here, Doug, as far as
Sure.
what we think is a good action item based on the conversation today.
Yeah, absolutely. So rather than say to any of you who may be interested, give us all this data. What we thought instead is we're going to provide as a follow-up to all of you that attended today, a short questionnaire that you can complete for us, take you just a few minutes, that'll allow us to do a basic assessment of your situation. If we think that you're going to be a good candidate for ICHRA based on what you told us in that survey, we'll contact you with what the next steps are for the formal evaluation. And you then can decide based on that whether you want to go through with it or not. If we don't feel, though, that you'll be a good candidate for whatever reason, now you may have ruled yourself in or out just based on being on the webinar today, I don't know. But if we look at it and go, oh, we have some concerns, we're still going to call you and get in touch and say, hey, here's what we're looking at, why we think that that we have some concerns about whether an ICRA would be right for you. So either way, we'll do that. Everybody that attended the webinar today, you will receive a copy of the slide deck presentation, a survey to provide feedback on the session, which we hope you'll do, and then again, a link to that questionnaire if you'd like us to assess your situation. I know many of you on the call today are employers that sponsor plans. Others are legal or financial professionals, or even just interested third parties. So obviously that survey won't necessarily be applicable to you, but you can look at it and you'll get a good idea of what kind of information we're looking to gather to help make that assessment.
Great job, Doug. Thanks. So we did have a couple of questions we did not get to, but given we're up on the hour, we will follow up in the question and answer transcript. So with that, Doug, if you just want to close it up, and thank you everyone for your time in your hour today.
Yeah, thank you. I'll make sure to look at your questions immediately, and we'll have the Q&A from, we did a session earlier this week. We'll add the questions from today's session to that, and that'll be included in all the follow-up materials that everybody receives as well. So again, Eric, thank you for moderating everything, and thanks for giving me the opportunity to talk about this exciting new benefits opportunity.